Morning, everybody. Dr. Gillard here once again. We are on week 5. It's Monday, so it's Endocrinology 1. Let's do our first endocrinology lecture today. And we left off with Addison's disease, so that's where we're going. Who's that? JFK, right? He was thought to have Addison's disease. Why was he thought that? Does anybody know? He always had this bronze skin look, this tanning, which is characteristic of Addison's disease. What's that from? That's right. Too much adrenocorticotropic hormone. Is that what actually causes it, though? Nope. That goes into the skin. There's your skin. And there's this little octopus-like creature called a melanocyte. When ACTH goes into the skin, it stimulates, it breaks down into something called alpha MSH. Alpha MSH stimulates the melanocyte to inject skin cells with too much melanin. The more melanin that are injected by the melanocyte, the more melanin that is injected into these keratinocytes, the darker your skin becomes. Trouble with the theory is this kind of tan thing from Addison's, although it can happen, but it often presents more patchy. It doesn't look too patchy to me. Well, I guess maybe he's a little lighter here, a little darker here, so maybe so. Another great mystery surrounding JFK. All right, what is it? Let's get into adrenal insufficiency. So, well, adrenal means adrenal gland. Insufficiency means it's not working. So, first described by Addison way back in 1855. That, in fact, this discovery was considered the birth of endocrinology. And even back then, they figured it out. It's a failure of the adrenal cortex, either all of the adrenal cortex or part of the adrenal cortex, depending, like tuberculosis can knock out the entire adrenal cortex, as we'll see. But it doesn't always have to be all the 3 components of the GFR, sorry. No frog in my throat here. Read the slide here. While I stall for time. Yep, so the big one is, in all of the different types, it's cortisol. Cortisol is not being released. Right? That's the main problem. Sometimes the DHEA is released as normal or decreased. Sometimes it's cortisol and DHEA. Sometimes, like with tuberculosis, it's the entire, no aldosterone, no cortisol, or DHEA. It all depends. But yeah, that's what it's from. It's a failure of all or part of the adrenal gland not to do its job. And we know the adrenal hormones, right? The mineralocorticoids, who's that? That's aldosterone. The glucocorticoids, who's that? Cortisol. Adrenal androgen, it's mainly DHEA. This is no joke. This can be a potentially life-threatening condition, mainly because of cortisol. If aldosterone's involved, though, cortisol and aldosterone, remember, you need those to stay alive. In fact, death depending on how old and strong you are, 3 to 14 days is all you can last without cortisol. You die of hypovolemic shock, hypokalemia, or it could be hypoglycemic shock as well. If you get a stressor during that time, it could add hyperglycemic shock as well. Rather than write that out, let me just make a note. 294. Add hyperglycemic shock as well. right? That can happen without cortisol. Still regarded as a rare disease. In fact, the prevalence of Addison's disease is about exactly the same as Marfan syndrome. 0.01% is the population prevalence. The prevalence has been increasing, probably because the baby boomers are old and getting more rheumatological disease and more lung disease, more skin disease. The treatment for those that have failed conservative care is glucocorticoids. And we'll see glucocorticoids is the number one cause of secondary adrenal insufficiency. So that's probably, in general, it's been increasing. That's the general prevalence. That's for all types of adrenal, not just Addison's disease. I should probably fix that too. It's interesting how when I lecture to you, I catch things that when I prep, I don't catch. There's two flavors. There is primary adrenal insufficiency, secondary adrenal insufficiency. Sometimes it's called hypoadrenalism as well. So I could have said hypoadrenalism for each of those. But let's look at primary. This is Addison's disease. When you hear Addison's disease, I think of Addison driving in a car insured by AAA insurance. The AAAs will serve you well. Addison's disease is a pathology of the adrenal cortex caused by autoimmune attack in most cases. But let's go through it. Addison's disease or primary hypoadrenalism, or AKA's prevalence, as we said already, 0.01%. Secondary is higher than this. Caused by some type of injury or something screwed up with the adrenal cortex itself. Therefore, if the adrenal cortex is screwed up, there goes your cortisol for sure, maybe your aldosterone, depends, maybe your DHEA. It all depends what the exact specifics of the disease are. It typically is caused by an autoimmune attack or an infection. We'll look at that more specifically. Number one by far is an autoimmune attack. Okay, so Addison's disease is usually autoimmune related, about 85% of the time in developed nations. In third world countries, it's actually tuberculosis. This type of primary adrenal insufficiency is called autoimmune adrenal insufficiency. There's the 3 A's: Addison's disease, adrenal cortex injury, autoimmune related will serve you well. Definitely not my favorite insurance company, though. They sure, I don't know how things are out there now, but boy, they sure were treating chiropractors quite badly back in the day. I won't say anything more about them, but I never have ever went with them. Favorite target of autoimmune attack? Favorite target of the who's the autoimmune attacking? Well, specifically, it's one thing. It's 21-hydroxylase gene. So AKA for that 21-hydroxylase is a CYP21, steroid 21 monooxygenase, 21-alpha-hydroxylase. I sure hope no professor would ever test you on that, but that's based on the P450 enzyme, P450-21A2. Let's hope that boards are just going to call this 21-hydroxylase gene. 90% of the time, that's the autoimmune. It could be other parts too, but if it's going to be an autoimmune attack, it's usually 21-hydroxylase. So we've talked about that, right? That's the gene that you have to have functioning to produce the enzyme 21-hydroxylase. And without 21-hydroxylase, you can't make two of the steroids. You can't make aldosterone or cortisol. Can you make ADH? Yeah, you can still make ADH. That's still typically made. So that's why this is still correct. The gene product, 21-hydroxylase, is needed to make all the major life-sustaining adrenal steroids. DHEA is not the adrenal steroids, or the adrenal androgens, those are not necessary for life. So that's why that statement is still correct. I do like the slide. Took some of the stars off it, but because I've already got one slide with lots of stars, I do like you to know that, the basics, right? Cholesterol, you should probably know pregnenolone. That's kind of the big first step. And then pregnenolone turns into aldosterone. It turns into cortisol, right? And it turns into DHEA. I mean, these are the three. These are the three big ones, right? How do you get testosterone? Androstenedione, DHEA, is converted to androstenedione, which is turned right into testosterone. Testosterone can be used to turn into estrogen. All right, or you can use androstenedione, can be converted into the other estrogen, estrone, estradiol. These are the two. Both of these, when you say estrogen, these are the major estrogens right here. Okay, but look at this. There's 21-hydroxylase. So if you have an attack against that, and it doesn't work, you can't turn progesterone into 11-deoxycorticosterone. So therefore, you can't make aldosterone. Can't make corticosterone either. That's one of the other mineralocorticoids, right? Is that right? No, corticosterone is actually over in this cycle. That acts more like an adrenal, or like a more cortisol-like function. All right, so bottom line, but look at, there's no 21-hydroxylase over here, so you can make DHE, you still can make testosterone. Everybody good with that? What about antibody testing? Can you test for this disease? Well, if you suspect your kid might have it, it's very accurate. 100% specificity, or 99%. Very, very high specificity for children, but for adults it's terrible. So about 50% of adults who test positive for this antibody actually never develop the disease. So just because the antibody's floating around, it doesn't always mean it's active. Maybe it's mutated, and maybe it's general enough to trigger the test, but it doesn't actually attack 21-hydroxylase. There are some concomitant diseases with this, the other autoimmune gang. Type 1 diabetes is always related to Addison's. Typically, the patient will develop type 1 diabetes during childhood and later on, maybe in the third decade or fourth decade, here comes the Addison's disease. Hypothyroidism, Hashimoto's disease is also common in Addison's. Vitiligo, right? This is a weird dermatological condition where there are no melanocytes in this region of the skin. If you don't have melanocytes, this is the kind of the background color of your skin. Very strange disease, how symmetrically it looks very symmetrical. We'll look at that in dermatology. Rheumatoid arthritis associated with Addison's disease. And then pernicious anemia, which we will talk about in GIGU this week. Some non-autoimmune causes, yes, of course, those are there. Tuberculosis adenitis is basically an infection of the adrenal gland with tuberculosis. And that's the most common cause of. That should really be third world. Let me just set it apart from that other slide. Third world, 306. It is people with AIDS also. The AIDS virus, for whatever reason, does like the adrenal cortex. Histoplasmosis likes the adrenal cortex. And cytomegalovirus likes the adrenal cortex. Unfortunately, metastatic disease from breast cancer or lung cancer can go to the adrenal cortex and knock it out as well. And people can get emboli in the adrenal cortex as well. People, especially people on anticoagulation therapy, warfarin, Xarelto, whatever it may be, they're increased risk for that. There are some other, or all of these causes typically result in destruction of the entire adrenal cortex. A destroyed adrenal cortex will not allow for the release of any adrenal steroids, right? So mineralocorticoids, glucocorticoids, adrenal androgens are out. Remember, autoimmune-related Addison's typically spares the zona reticularis, right? So DHEA is still released, but not these bugs. These bugs don't care. They destroy the entire adrenal cortex, so all of your hormones will be out. All your adrenal steroids will be gone. Don't confuse adrenal steroids. I do that sometimes myself. Adrenal steroids, that's the parent category for the children. The mineralocorticoids, aldosterone, the glucocorticoids, cortisol, and the adrenal androgens, that's DHEA. Don't confuse these two together. Adrenal steroids, because they're all steroid derivatives. Why? Well, cholesterol, right? Who's the granddaddy, or who's the daddy of them all? Right there. They all derived from this steroid molecule. See, they all have that steroid form. All right. Got that. What about if you order some blood work? So primary adrenal insufficiency patients. Now, it's usually, what's the cause of primary Addison's disease? What's the usual cause? A autoimmune attack. And usually, so autoimmune attack will knock out zona glomerulosa. It usually, it does knock out the zona glomerulosa. Usually knocks out cortisol and aldosterone, right? But it sometimes misses the zona reticularis. So therefore they'll have, for blood work, they'll have decreased cortisol, they'll have decreased aldosterone, they'll have super high levels of ACTH. Why will they have ACTH? Who shuts down ACTH? Remember we talked about ACTH last time. So increased cortisol levels, they knock out the production of the corticotroph cells. So ACTH can't be made, right? Because they go down here. It's a double negative feedback system. Remember that? And then they knock out the protection of CRH, corticotropin releasing hormone, from the hypothalamus. Paraventricular nuclei, parvocellular neurons secrete CRH. So it knocks both of these guys out normally. Therefore, that's when it's normal. That's when it's increased. But if it's not increased, there's nobody to turn the system off. So ACTH just gets cranked out like crazy, and you get super high levels, blood levels of ACTH. ACTH is trying to stimulate these guys, trying to stimulate cortisol anyway, but it doesn't do so. And typically, you'll have normal levels of ADH because usually, as we explained, the autoimmune attack, 21-hydroxylase is not in this pathway, so DHEA. You would think it might even be high, right? Because you got ACTH stimulating the reticularis. So it could be even high in some patients. Got to be tuberculosis or one of those others to have all three of the adrenal steroids knocked out. Are we good? All right, let's look at secondary adrenal insufficiency. Now, this one is more common than Addison's disease, about twice as common, 0.02. It's still fairly rare, although it is increasing, still fairly rare. The adrenal gland is functioning normally in this one. This time, something's messed up with the HP axis. What does that even mean, HP axis? So the hypothalamus and the pituitary. Don't confuse that with the HPA axis. That's the hypothalamus pituitary adrenal axis, right? So there's nothing wrong with the adrenal gland. So that's not in this, what we're talking. We're talking about the HP axis. So something is screwed up either in the hypothalamus and or the pituitary, specifically the anterior pituitary itself. Bottom line is no ACTH is released. Will these patients have bronzing of the skin? No, they won't, because you have to have high levels of ACTH to soak into the dermis to stimulate alpha MSH, which in turn stimulates melanocytes to release extra melanin in the keratinocytes. If you get extra melanin in the keratinocytes, they're dark and your skin starts getting dark. All right, so no problem with aldosterone? Is that true? Yeah, how come there's no problem with aldosterone secretion? Yeah, good. ACTH doesn't stimulate aldosterone, right? So glomerulosa is stimulated by who? The R2A system, but who specifically? The Tasmanian devil, right? Angiotensin 2 stimulates that. Right, so decreased ACTH means decreased cortisol and decreased DHEA as well. Now remember, ACTH does stimulate, it can bind with the glomerulosa cells a little bit. So aldosterone might be down a hair, but it's not clinically significant. Full power secretion is turned off, but what's the number one cause? This is surprising. It's iatrogenic. What does that word mean, iatrogenic? It's an iatrogenic hypoadrenalism. It's man-made, is iatrogenic problem. And the problem is that these patients are taking glucocorticoids, glucocorticoid therapy, prednisone, hydrocortisone, dexamethasone, are just 3 of them. Why in the world would you be doing that? Your patients are going to come in to see you, you chiropractic patients. Well, all your patients eventually will be coming in to see you, and some of them will be on glucocorticoids. They'll say, I'm on steroids, but they're not on anabolic steroids. They're on glucocorticoids. They're on glucocorticoids, which is a form of steroid. That's what they're on, probably prednisone or hydrocortisone. How come? Well, they have chronic inflammatory disease, COPD, all sorts of respiratory problems, asthma, treated with steroids. Gastrointestinal problems are treated with steroids. Musculoskeletal, rheumatoid arthritis, you name it. Prednisone, very common. Your patients will come in or they've at least just been through a 10-day or 15-day course of prednisone. And then dermatological conditions, all sorts of them. We use steroids all the time in dermatology. All right. So how do these exogenous, what's that mean? Exogenous glucocorticoids. Exogenous, another way to say that. Exogenous means they're coming from outside the body. You're taking them on purpose, and they're not part of nature. How do exogenous glucocorticoids cause trouble? Well, just the body doesn't know them apart from cortisol. And so therefore, once you start taking them above your physiological normal production of cortisol levels, which is about 7.5, give or take, it's not uncommon to take 10 milligrams on a prednisone dose pack or Medrol dose pack. You can take pretty high levels. But once you get above that natural threshold, well, your body doesn't know it's going to inhibit the hypothalamus and inhibit the anterior pituitary to stop making CRH and ACTH respectively. Therefore, these patients, especially who've been on them for a couple weeks. Normal course is maybe 10 days. But if they've been on them a couple weeks, I mean, some people have been on these for years and years and years. Mother-in-law has been on these things probably for 30 years because of her inflammatory conditions. And so therefore the patients, they don't have a natural release of ACTH. Well, how come they don't? If you don't use it, you lose it too, by the way. Well, this is that system we just said. Exogenous glucocorticoids will also knock out parvocellular neurons in the paraventricular nuclei, so you won't no more CRH. And if that doesn't work, they knock out the corticotroph cells in the anterior pituitary. No POMC ACTH, those are gone. And so no ACTH, right? Because it's been turned off. How do they so what does no ACTH do? Well, if you don't have ACTH, I mean, that stimulates all three, mainly the zona fasciculata and the zona reticularis. They atrophy like crazy. You don't use it, you lose it. And that machinery in the adrenal gland shuts right down. So what? Well, what happens when you stop taking the glucocorticoids? So what? You got to restart the machinery of the adrenal cortex. And I'll show you a new study. I actually read it this morning and put it in here. I was like shocked. I didn't realize it was so, this is such a big problem, but it is. But it takes a while to start that HP axis. That's why you go in a tapered, when you don't just quit taking glucocorticoids cold turkey. Because then you could go into hypoglycemic shock if that occurs. You have to slowly stop taking them and kind of let your adrenal glands start to wake up and start working again. And sometimes the HP axis never works again. And you'll be surprised at this number here that's coming up. So until your adrenal cortex, especially the fasciculata reticularis, start functioning again, you're going to have secondary hypoadrenalism, right? And that's the definition of this. So this is very dangerous. It can cause what's called an acute adrenal crisis, which can kill you via hypoglycemia more than anything else. And we'll talk about that one when's our next class? I think it's on Wednesday. No, actually it's Tuesday. Yeah, so we'll keep talking about that when the time comes. But without cortisol, you can't make blood sugar. You can't stimulate the release of blood sugar from the cells and muscles and kidney. It's very important for that. And if heaven forbid, a big stressor, you fracture your femur or some major stress happens, get sick, get the coronavirus, you're in big trouble, right? Because your body soaks up all the sugar like crazy fighting the stress, and you got to make more sugar than normal, and you can't do it without cortisol. Here's the study I just read this morning, the Joseph study. It's from England, but very prestigious journal. It's published in with an impact factor of 5.2. That's pretty, like for example, the journal Spine is I think 3.5, and the Spine Journal, those are the number one spine journals in the world. That's also about 3-ish. And it's not the Lancet or the New England Journal of Medicine. Those things are over 50, I think. But it's kind of a little because those are kind of general journals, so they get higher numbers. This is really high. This is a good number, one of the most prestigious journals. And they could have done a meta-analysis, but they decided that the quality of the research is not the greatest. So they went with a systematic review. They looked at, I think it was 650 studies, but they cut it down. Only the highest quality studies made it in, 73 studies, and they pooled all those patients. 3,166 patients were looked at statistically to see how many of them developed hypercortisolism after they stopped their cortisol therapy or the glucocorticoid therapy. And amazingly, to my surprise, 15% of these patients had adrenal insufficiency 3 years after the study. And some of them were even further than that, and they didn't go any further. It'd be interesting to follow up in 10 years. That's a huge number. And the other scary thing, I had always heard that it was dose dependent. The higher dose of steroid you want. In fact, Robbins and the board books say that it is dose dependent and duration dependent. But this study surprisingly found no relationship to the dose. Even some patients taking as little as 5 or even under 5 milligrams per day, some of them, their adrenal gland just didn't come back to normal function. Albeit most of them, the majority of them, were on glucocorticoid therapy for more than 12 months. So they had been on it quite a long time. But there was a good chunk of the population that was between 1 month and 12 months. So it wasn't as long as I thought. But I was suspecting maybe 2%, not 15%. And that's a big study. Interestingly, that about the same time as the Joseph study was published, another study came out, another systematic review. How you say that word? Broserson study came out at the same time. They found big numbers as well. But the difference on that, they did find a dose and duration relationship. Statistical, which I'd always heard, and that makes sense to me. If you're on super high levels of glucocorticoids, I think your chances of you knocking out your adrenal cortex where it doesn't come back are much higher, and that's what that study. But this study didn't, so I guess that's a little up in the air still. So yeah, that's a big number. So you got to watch out for patients coming off these steroids. Never tell, some chiropractors are so anti-medical that they start taking care of a patient. They say, well, you don't need medicine. Chiropractic will cure everything. I hope there's still not chiropractors like that around. You need to stop taking all your medication. You'd kill them. You'd kill the patient if they're on glucocorticoids for a year and you told them to stop. You can't do that. We got to work with medical doctors. We're all part of the healthcare family. We all have to get along and we all have to work together. I hope that stuff still doesn't go on out there, but that's a warning. I mean, you don't ever stop this stuff cold turkey. Here's a case where you'll kill them for taking them off their medication. So watch out. All right. Just did the Joseph study. Adrenal insufficiency. What about stress and adrenal insufficiency? Well, it can be really dangerous on people who have just come off or people who are on a fixed dose. Let's say you're on 20 milligrams of glucocorticoids or on prednisone, and that's it. Your adrenal gland is shut off. You can't make any more of that. What happens if you have a major stress? You're in a car accident and you fracture both your femurs. That's a major, major stress. Your body's going to be utilizing glucose like crazy, more than 20 milligrams of it. So how are you going to make more of it? You're not going to make more of it. You're going to probably pass out because of hypoglycemic shock. Same thing when people are trying to come off and tapering down, they're particularly vulnerable. People who are on these long-term, they have to calculate that, okay, here's a major stress. I'm having a stressful day. I need to up my dose a little bit. It's really, really tricky. So that's why it can be dangerous. You kind of have to act as your adrenal gland when you're in glucocorticoid therapy for major stresses and things like that. All right. Everything I just said there. So if your adrenal gland is not functioning, you have a major stress, everything I said, you will become hypoglycemic unless you take more, which these patients who've been on this for a long time, they do. They have to learn how to take more. How does hypoglycemia kill you? Hypoglycemia is low blood sugar. Probably a lot of people have gotten a little hypoglycemic and you get dizzy and you get sweaty. You're starting to go into hypovolemic shock. but you eat a candy bar or drink some orange juice or apple juice or something with sugar, and you kind of, within 5 minutes, 10 minutes, you kind of come back online. But hypoglycemic shock, if you don't have access to that sugar, you're in trouble. So your brain will run out of sugar, it'll stop working. Your heart will run out of sugar and stop working. Your kidneys, your liver, that stuff all needs glucose to function, right? So your whole body will shut down. Okay, so what's the solution for those with hypoadrenalism? Well, major stressor occurs, as I just kind of said this already. If a major stressor occurs, you have to take more than your usual dose of prednisone or methylprednisone or whatever you're taking. That's easier said than done because it's very hard to kind of get the hang of, how much stress you're under and how much extra you have to take. Okay, another warning: never stop taking glucocorticoids cold turkey, right? Because your adrenal gland is shut off, especially if you've been on it then more than a couple days. Right? If you've been on it 10 days, you can be in trouble from that. But it's usually more for the people who've been on it for 6 months or 2 years. You got to really back down slowly. But as I've already said, glucocorticoid therapy shuts down all the machinery, the parvocellular neurons. The corticotrial cells don't work. In fact, the zona fasciculata and reticularis, those guys are shut right off. They actually atrophy, so physically there's a problem there. Therefore, you can't make additional ACTH if you need it, or you can't make cortisol as you need it. I think we kind of covered this already. And again, never stop taking it abruptly. It can kill you. Everything I said already. There it is in writing, so I can test you on it. So the solution, I said this already too, you have to taper off the glucocorticoid therapy, prednisone, methylprednisolone, or whatever you're taking. You have to take it off to give your adrenal cortex a chance to start waking up and start working again. And so, it's easier said than done, though. People who've been on it a long time can be really, really difficult. Prednisone on long-term doses above physiological level, even tapering is not going to work right away. If you've been on it for 6 months or so, you will develop hypoadrenalism, secondary hypoadrenalism, for quite some time after that, and it's not easy getting off that stuff. Long-term, very high doses, you could have permanently damaged your adrenal cortex, and it may never come back. It could take years. Look at that study we did. 3 years for some people. Many people who weren't even taking it less than a year got hypoadrenalism for at least 3 years. Who knows beyond that? How about some other causes of iatrogenic secondary hypoadrenalism? Well, iatrogenic usually means, I always think, some type of exogenous steroid, corticosteroid, and there are other types besides prednisone and the ingested types. There's inhaled corticosteroids for people with the COPDs. There's topicals for the people with the dermatology problems. You can get people with chronic joint pain. They can get intra-articular injections. Too many of those you have to be careful with. There's steroids you can rub in your eyes for eye problems. There's rectal corticosteroids, suppositories that you can use. There's progesterone is a steroid as well. If you take too much of that, that can shut things down. For breast cancer, that's used. So there's some other causes. Even more causes. Now, these are not iatrogenic causes. These are just other causes, not man-made. But rarely there are mutations in the POMC gene, which makes POMC, which is converted to ACTH. So there's SOC3, there's PROP1, there's a POMC synthetase. That's just the mutation in POMC itself. But there's a SOC3. These are other genes that are used to make POMC. So mutations in any of these three will cause secondary adrenal insufficiency or hypoadrenalism. AKAs. Another common, this is an iatrogenic one, another iatrogenic one is following a pituitary gland surgery, most commonly for Cushing's syndrome, where they have a pituitary in their, or where they have a tumor in the pituitary gland. Prolactinoma is another really common type of adrenal or anterior pituitary tumor. The surgery, the swelling after the surgery, can knock out the corticotroph cells. Right? No corticotroph cells, no cortisol. So that's another. You need time to heal. The system needs time to heal. The anterior pituitary needs time to heal, etc. All right, clinical features. That's probably enough today. That's like 30 slides. I mean, we can go this far. It can be really tricky to diagnose adrenal insufficiency. It's slow. It usually comes on slow and insidious, and it can become life-threatening, right, with the passage of time. Some of the classic features by studies, here's an example of why it's so tough to catch. Look at these. So these are people who actually had adrenal insufficiency. These are Addison's patients that this study was done on. But weakness, tiredness, fatigue. I mean, the first thing I think about is your thyroid. They have hypothyroidism. It's the first thing that comes to mind. But maybe it's a adrenal insufficiency. Maybe they have autoimmune disease. Weight loss, 100% of patients have that. Hyperpigmentation, 94 are very strong. They start getting brown blotches all over their skin. Gastrointestinal symptoms are very common as well. But I mean, it's hard to diagnose all this, right? These could be so many different problems. Although the hyperpigmentation really makes you start thinking of primary adrenal insufficiency. Although there's parathyroid hormone disease of the parathyroid hormone can cause this, and there's other ones that can do it as well. Hypotension, tachycardia, hyponatremia. I mean, you can see it's a really tough diagnosis to make. Yeah, let's stop it right here. It's a good place to stop. All right, see you tomorrow.